people and the minions in the room?
Yes, yes.
Okay, they can hear us. Alright, so let's just begin with our case.
Can you just reduce the volume a little bit? Small.
Can someone reduce the volume, please? It needs turning preferably off. Need volume down.
Aziz, mic को प्रेस कर दो और फिर now you
Okay, so this is a 31 years old gentleman. He has been prior to
you cannot hear you properly. Wait.
Can you hear me?
No, not you. Is the mic on? Yeah.
Is it on? Can you hear me?
Thank you. Is that better?
You can hear all very well. We can't hear you. Can you hear me now?
We can hear you, but
Can you hear this?
Yes, we can hear you now.
okay. Is it better now?
Yes, better.
Okay, so this is a 31 years old man. He basically has no known comorbidities and he has been having purulent discharge from the perianal area that has been on and off for the past 2 months. No abdominal pain. He had one episode of bleeding PR a while back. So general surgery team has basically asked us to do a full colonoscopy on him, suspecting a fistula basically.
Okay.
Be pushed in. Sedation. Right, everyone, can you see? Most importantly, there's a chap stood here all the time, and because the cot side's down, and there's a chap that side. So what we're doing is protecting the patient from falling off. I've already introduced myself to the patient, told him who I am, and told him what we were going to be doing. So the idea is that when we do this, is just to do it nice and steady. Yeah. I've been asked the question how long I'm going to take. I always say it takes as long as it takes, but there is a limit on how long I will be willing to take. The scope guide's set wrong, it needs to be pointed this way. So the arrow.
How much sedation has the patient got?
So I gave him 2-2. So see the blue arrow? No, it needs the orientation of the blue arrow. That's as if he was on his back. That means he's on his back. Hello.
Can you share the sedation, please?
Oh, that's 2-2.
Midazolam and 2K.
Thank you. So the blue arrow on the needs to be pointing this way. Yep, the other one. Keep going. Next one. Yep, that. Oh, thank you. So what we've done is that we've set the orientation of the scope guide. That's what we were doing there. Did you see that?
Are you familiar with what scope guide is? Anyone?
Lota, just going to examine your bottom, okay?
Before?
Well done, my friend. Well done. Okay? Now the scope goes on the bed, and now I'll cover that back up just. This man keeps lifting his head off the pillow, he's a little bit unsure about what's happening. If you look, you can see the scope on the bed here completely. And I'm looking up now at the scope. I'm going to put my hand underneath just so that I can then do the clockwise tilt that I want to do at the moment. Now, I'm actually going to do what I always do, which is I always do that at the beginning. Yep. Now you let go of the scope. Now some people don't like you doing that because they say you put too much air in to actually accomplish it. So I've gone forward now.
Well, can we just ask them to just show us the scope guide, the monitor, the actual thing there?
You want it smaller?
No. I mean we can't see the scope guide. We can see the monitor. No, we just wanted to see the actual device.
Oh, you want to see the device?
Yeah. So ask him to focus there, please.
Can you just focus on that? He wants to see the scope guide. He wants to see this. Is that what you want? Is he happy? Yeah. He just wanted to see the machine apparently. Right people, can you see what we're doing? We're keeping the anti-clockwise torque on, anti-clockwise torque on. If you look at the scope guide, you can see what the scope guide's doing. I'm not advancing the scope in any way, shape or form at the moment. Now if you're going to reduce any loop, there is no loop formed at the moment. I take a look down at the patient and then I take a look across here. I didn't put any air in either at that moment in time. But I'm going to actually draw the scope back. And now I'm going to go forward. What is all that noise? If you look at the hand, the finger is pointing in the direction to go. Now I'm going to turn the scope so it comes clockwise. I keep the clockwise on. Now my hand's going underneath. See how I'm keeping this straight? This is the most important thing. Keeping that straight. As I draw back, and now I let the scope go forward. Hand goes over the top because now I know I want to do anti-clockwise. And I'm still drawing back. So when you're reducing a loop, it is not always one torque. It is both clockwise and anti-clockwise. Clockwise and anti-clockwise. When you're ever going to be reducing a loop. A lot of people get caught into the confusion that it's one or the other. Just clockwise. Combination. There's a lot of people in here. Rima. If you're wondering what I'm saying is that I suffer in Pakistan with the heat. I love coming, but the heat kills me. Look at the folds. Can you see the folds here? Now, see here the teeny eye. The folds tell you which direction to go. So where do you think the direction is? 5 o'clock. So I won't turn to 5 o'clock. I'll do a clockwise torque now to bring 5 o'clock to 12 o'clock. And I'll just wait a second. Draw back the scope. As I draw back the scope, I now know it's off to the left. I'm looking down at the chap. Anti-clockwise, clockwise, anti-clockwise, clockwise, anti-clockwise, clockwise. Tip down, anti-clockwise, clockwise, anti-clockwise, clockwise. Blip suck. Did you hear what I said? Blip suck. Not suck. Blip suck. Keep the clockwise torque on. Watch the right hand. Clockwise torque on, scopey straight to the body. Suck, suck. Suck, suck. Draw back. Suck, suck. Draw back. Wait. Advance the scope. Advance the scope. Loop is slowly reforming if you go by scope guide. Patient is comfortable. His shoulders come back slightly, so I'm always aware of when shoulders come back, what that can mean. That can mean that it makes it a little bit more difficult to progress a later time because the patient is in a position, an orientation that makes it difficult for you to progress. So you just keep an eye on things. He's wanting to see the screen. So I don't know if he's watching the screen I'm watching, even though the one in front of him will show him what to do, what's going on. So I'm not putting any air in. Can you see there? There's no bubbles, no air whatsoever. Not putting any air in, just let it sit there. Put the clockwise torque on again, hand underneath because I want to do clockwise torque. anti-clockwise torque, clockwise torque, anti-clockwise. I'm going to come back even further anti-clockwise and draw the scope back. Suck to hold and let the scope go forward. Clockwise torque, draw back, keep drawing back. I want to do more clockwise, keep drawing back. Now to interpret a scope guide, if you look you can see grey, and you can see grey at the tip, so those two things are for real. The bit in the middle is a different colour, so the scope guide is guessing where it is. That's why it's a different colour, because they say it's out of sight of the actual guide itself, out of detection. So a scope guide is a series of rings that are picked up by the actual detector itself. Now look at the scope, it's nice and straight. Scope is perfectly straight there, but that doesn't mean anything. Absolutely means nothing. Because what you need to do is keep coming back, and we're not placing any tension at all on the bowel. Keep coming back. I'm underneath the fold. I can tell I'm underneath the fold because it's darker above. So that means I'm underneath something. There, can you see? Now I know where I want to go. Where do I want to go? It's here. Remember when I said about your eyes and being caught and your finger across your nose? So a slight clockwise torque, a little bit more clockwise torque, and now back. Now I know if I continue with this, I'm going to cause a loop. So I'm going to keep the tip where it is, and I'm going to go anti-clockwise completely, and then draw the scope back. Tip up, and let the scope relax. Just a little bit of a blip air. I try to keep the air to an absolute minimum. Now a lot of you guys will keep going forward. I draw the scope back, and now I go forward. Tip up. Tip up. Tip down. Now the scope's getting a little bit difficult to advance. Two reasons for this. One, you could say, is it a loop? But I know it's the gel. Okay. Gel, please. Now, so I put it, this is something you won't like to do. I put it on my fingers, I then draw the scope back, and then I put it on the scope. Always on the fingers. I like it on there because now it slides forward. As I advance the scope, I don't ever put it direct on the scope. I will put some onto the anus if necessary, but I won't put any on the scope. I find that, you know, a big blob of it, I get out of the habit of doing it. So now, we're advancing nicely. I'll take a look down at the patient again. I'm looking at the observations. This is the thing that you need to get used to. Check the observations. I heard a noise then, so I stopped what I'm doing and I checked on Rima. Everything okay? Yes. So soon, if I hear any conversation in the room between the patient and the nurse or anything like that, or the tech people, I will actually stop. Come back, come back. Now, we're on the verge of coming back too far. Keep the scope going there, and now nicely advanced. Tip up, tip up, tip up. I look down at the patient to look at his eyes. I wait for the spasm to go beyond. Now, there are a couple of ways of actually reducing this spasm. One, you could put Buscopan in. Two, you could put warm water in. So, which I might do in a few seconds. I don't want to go any further.
Paul, do you think it's the warm water or is just the water?
I think cold water is okay, but I like warm water, to be honest with you.
You know, I used to use warm water before, but since the jet has come, I just put water from the jet, and it opens up everything almost similar to when I used to put warm water. I don't know if that's your observation.
And we're all connected. So I'll put some water in. Count to 3, 4, 5, wait, let it finish, and then come back. If you notice any suction that I do, and I know SARD's similar, we do it for a very short period. We don't do it for a long period at all. The reason for that is that we catch the mucosa very easily, or you'd catch the mucosa very easily. So we don't like you to do it too quickly, too much. I'll just advance a little bit more. Now, there's an old-fashioned way to get round here, which is the way that I can do to show you, or there's a more modern way. So the more modern way is to just put the tip forward, clockwise torque and draw back and then go forward. What I used to do in the old day was a little wheel forward, big wheel back and walk away from the scope, and people would go beyond, be amazed. Just roll back a little bit. So, is he okay?
Well, that I don't think many people understood that.
Ah, right. Well, you do, because you've seen me do it. Right, now, just a little bit more water. Now, if you look, wheels are neutral. Now, if you go by scope guide will suggest that my splenic flexure would cause me a problem. Some people swear by scope guide and would react to it. I react to the feel of the scope. I don't react to what scope guide's telling me. Is he okay? And now, if you hold the scope here, I bring the scope back up. That's put a loop in the scope, one in the umbilical. Some people don't like it, but I'm afraid it reduces the amount of movement that you put into a patient. So they don't have to roll onto the back. I'll come back and come back, and now you can go forward and come back again. Keep the torque on, keep the torque on, and now go again. Wonderful. Right. Could he come onto his back, please? Now, the scope guide, can it be pointing down? The arrow pointing down? Now, if you notice, I've manoeuvred the scope while the patient was actually, this is something that I do. It's not something, if you're in your early days, I would get you to do. But the reason I do it is that their abdomen, as they go onto their back, tenses up, and it enables the scope to go forward. So I draw back the scope, and then the scope will go forward as a result. Is he okay? Now, the only reason why I'm using the little wheel, if you also notice I haven't used it till this point, is that I know where I am, and I'm just adjusting everything to make sure that I can see all aspects. Wonderful. So, any comments? So I take the loop out now he's on his back. Ah, yeah, pup. Oh, you dog. This is me trying to get into terminal ileum, by the way. Did you see my body sway down? I was going, go on, go in, you pup.
So,
Yes, boss.
no, I'm just, you're just trying to get into terminal ileum.
Yep.
And so we can just, I was just thinking, while you're doing that, you can just share quickly what your maneuver.
Sorry, my friend. Oh, what a foot. There you go. Okay. Happy in the room? Excuse me, sir, just need to check something.
Sorry.
And we're in the terminal ileum, my friend, and that's approximately 65 centimetres. So 65 centimetres means nothing.
Yeah. Well demonstrated. Paul, well done.
On the way back now, everything's covered. Scope is here. That is there. Stand square to the bed. Hold the scope, and as I come back, hold the scope here. That's not saying that you should. Can you see at the bottom a quarter fold? Bung off, do not suck. Big wheel up and down. Do not suck. Up and down. Keep the scope here. Draw it back nice and steady. Let the scope flick between the fingers. Nice and steady. Come round. Nice and steady. Up and down, nice and steady.
Paul, I see a little bit of haziness on the right side of your screen. So, not sure if you...
What I'm going to do is just turn into the wall, spray some water.
Yeah, okay. That's better.
Pause. Now there's a lot of spasm there, so you just wait. Put more water in and just wait. And wait. I'm not putting any more water in. Now a little bit of air. And there you go, it opens up. Hold there, go above it, below it, see in between it. Hold there, above it, anti-clockwise, opens up. You see? Anti-clockwise, clockwise. Clockwise now to hold that fold down. Clockwise, go past the fold by turning to the clockwise. Now you'll hold it down. Anti-clockwise. Tip up. Don't suck continuous. Suck intermittent. Blow continuous. Suck intermittent. Blow continuous. Suck intermittent. Blow continuous. Suck intermittent. Blow continuous. I know it's a boring conversation. Suck into me. Low continuous. If you think you caught mucosa, bung off, and away you go. Don't suck completely down because you never will. I've kept the patient on the back. The reason for keeping the patient on the back is that the scope will come back in a uniform manner, not dropping off and losing it. So I actually like to withdraw the scope with the patient on the back where possible. However, if I was successful to get the scope all the way round on their left side, I will leave them on their left side. I'm not desperate to change position because it says so in a book. Yeah, no problem. That's the reason why. If you look at the wheels, you can see that the little wheel is neutral. And you can see that the big wheel where it is. All I do with the big wheel is up and down every now and again. That's all I'm doing. If you look at my thumb just adjusts the big wheel. I do nothing with the little wheel. If I want to have a look at something, I'll rotate the scope. There you go. I'll draw back. If I want to have a look at something, big wheel only. Can you see the big wheel again? Big wheel only. Little wheel you leave alone. Hand goes along the scope. Tip up. Scope comes back. Clockwise, anti-clockwise. Tip up. How do I know it's tip up? That's a question to the room. How do I know it's not tip down? Question to the room. I'll do the next one. And I'll say to you, right, where's the next one coming from? And it is tip down. How do I know it's tipped down? How do I know? That's me. How do I know it's tip up? Saad will ask you the question because you'll understand it better from him. Just for those people who can understand me well, what it is where the brightest area is, you always go to the dark side. So because it's bright at the bottom, I know I need to do tip up. Because I know it's dark here, I know it's tipped down. I'm anticipating next to, it's bright from the right, there's glare from the, so I know it's anti-clockwise. Tip up, tip down. See the elbow doesn't come away from the body, the right elbow, the scope is sitting in my fingers, I'm not dragging it, I'm not pulling it, I'm just letting the scope roll. So there's none of this gripping of the scope. I'm not asking you to do that. You will, as people who are developing the skill, you'll be able to do this eventually, but you won't be able to do it initially. So just learn to hold and caress the scope. And I'm not being rude by saying caress the scope, because that's what it needs to be. It needs to be actually supported and caressed through what it does, not forced through what it does. Fingers go along, support the scope. Draw back the scope. Clockwise talk. Let the scope return to the bed. See the...
Paul?
Yes, sir.
When you're withdrawing scope, do you always have your patient supine? Or is it because you already had him supine?
I had him supine. Ideally, in the UK, I would have him on the back because I like it to come back that way. There's more control on the scope. However, if I'd have got to the cecum with them in their left lateral, I would have left them in the left lateral. Because why disturb something that's, you know... So I don't disturb the patient. I try to do it the minimal. I won't get into the rectum and then say, right, put the person in the right lateral to negotiate the sigmoid. Right, put the person on the back, now put the person in the left lateral to get round. I don't do any of that rubbish. I only adjust position when I have to adjust position. Not because it says so in a book.
Okay, thanks.
So can you see the glare from there, and it's dark from down at 7 o'clock, so I know to turn that direction. Still glare from there, see it? So I know yeah. the only time you go to the dark side. God, I've been talking for ages. Oh. See there now, it's bright to the right, so I'll let the scope. See how much clockwise torque I applied there? There's an awful amount. And again now, anti-clockwise and tip up. So I don't bother about what I have to do. I know which direction I want to take it. See? Now if I was to let the scope relax, it's in the middle of the lumen. If you look at the little wheel again, the little wheel is showing you that it's still neutral. I haven't touched the little wheel in any shape or form. It's a two-handed procedure. At no point have I touched the little wheel. Coming back. Hand underneath just to make sure that I can support it. My arm is supporting it, not anything else. I'm under the fold so I know to come back, tip up. Have a look around. Anti-clockwise. Scope wants to fall back. Just relax the scope. Let it do what it needs to do. The scope is an extension of your arm. So if you want the scope to look left, turn it left. You want it to look right, look right. It's an extension of you. And that means if you're in a bad mood, the scope will be in a bad mood. If you're in a good mood, the scope will be in a good mood. So if you're going to scope and you don't feel happy, take yourself into a professional space and make yourself happy. Paying a bit of attention here because this is rectal area and I just want to make sure and that's it. Once you've taken the scope out of the patient, suction. Suction continuous till you hand it over. Hand it over, two separate hands and away you come. And keep your hands together so you don't cause anybody.
Why would
Because any liquids, any body fluids, and you keep them dragged up the scope.
Thank you, sir. That was really nice.
Oh, look at these two. Look at these two.